So today we'll discuss refractive areas of the eye. Refraction. Refraction is the bending of light when it crosses an interface between two media of different optical densities. In this case we have a light ray that goes from air, which has a lower density, into the cornea, which has a higher density, and as a result the light is bent. So a ray of light that enters the eye is first refracted by the cornea and then by the lens. And these two structures are responsible for the refractive power, or most of the refractive power of the eye. The refractive power of the cornea is much greater than that of the lens and accounts for about 70% of the refraction of light into the eye. Here's just a model sketch of the eye showing the adult eye where the axial length, or the length from the front of the cornea to the retina, is between 22 and 25 millimeters, and it just shows parallel light rays coming from a distant object, which in a normal eye focuses directly on the retina. So this condition is called emmetropia. So if the refractive power of the eye and the length of the eyeball are perfectly matched, parallel rays from a light source from a distant object are focused on the retina when the ciliary muscle is relaxed. The result is then a clear image of the object on the retina. This perfect refractive condition in the eye is then called emmetropia. So as you can see, parallel light that enters the eye from a distant object is focused directly onto the retina. The next subject is accommodation. In a relaxed emmetropic eye, distant objects are focused on the retina, and this is shown by these solid rays, but near objects are focused behind the retina and are as such out of focus. Now we'll show what happens to a near object. Which is focused behind the retina when the eye is not accommodated, or when the eye is not focusing with the lens. So accommodation then is the process whereby the refractive power of the lens is increased in order to bring into focus the image of a nearby object onto the retina. So parasympathetic stimulation causes contraction of the circularly shaped ciliary muscle. The effect of this muscle is to relax the lens zonules, and this allows the lens to assume the more convex shape of its relaxed state. So the relaxed state of the lens is actually a more convex or ball-shaped shape. So in this picture one can see that the ciliary body, the ciliary muscle is relaxed, but when the ciliary muscle is relaxed, the lens zonules over here are tight, and they pull onto the lens and makes the lens more flat in shape. So there's no accommodation in this instance, and a near object will not focus on the retina, but it will focus actually behind the retina and as such be out of focus. But when the ciliary muscle contracts, the lens zonules over here and over there relax. So instead of the lens being pulled flat, it has a more rounded shape which increases its refractive power and then can focus light onto the retina. So when the eye is accommodating or the lens power increases, the image can focus on the retina, a near image. An image of a near object can focus on the retina. So the main refractive errors are the following. First, we'll discuss presbyopia, or old person's eyes, as some people call it, old man's eyes. Over here, the lens progressively basically loses its elasticity with increasing age, and as a result there's a decrease in accommodative power. So the lens is always stuck in a more flat kind of shape and doesn't assume its round, more convex shape when the lens zonules relax. So in an accommodative state, in a young person, you'll have the lens becoming more round, while in a presbyopic patient, even when the lens zonules relax, the lens will still remain in that more flat shape. And this loss of accommodation then with age is known as presbyopia. It occurs in all people, irrespective of their refractive error. So symptoms of presbyopia usually start at the age of about 40 to 45 years. The person experiences problems focusing on near objects despite good distance vision. Near vision is worse in poor light and with small print, and it then becomes necessary to hold things further away in order to see them clearly. So you'll typically see people holding a menu at a restaurant far away from them, especially if the print is small. So here is what happens. The lens remains flat even when the ciliary body contracts. So it doesn't assume that round shape, so there's no accommodation, and the image is basically focused behind the retina and is out of focus. So correction of presbyopia is with a convex lens to correct near vision. This correction is in addition to any other correction that is needed for distance vision, and it may be in the form of bifocals, or some people prefer to have different glasses for distant viewing and for near, and then they will have a separate pair of reading spectacles. And here it's just shown that with a convex lens or reading glasses, one can correct presbyopia and let the image from a near object focus onto the retina. Ametropia is the opposite basically of emmetropia. It's a refractive error. It just basically means that there's an imbalance between the refractive power of the eye and the axial length of the eye, and that is called ametropia. And ametropia basically just means that in the unaccommodated eye, a distant object is not focused properly on the retina. And there are three types of this refractive error. Firstly, myopia, secondly, hypermetropia, and thirdly, astigmatism. So, myopia or short-sightedness. The refractive power of the anterior segment, meaning the cornea and the lens, is too strong for the axial length of the eye. So parallel rays are then focused in front of the retina. So myopia usually results from unusually long axial length in an eye with a relatively normal refractive power. So such patients can sometimes have prominent eyes, and less commonly the eye may actually have an unusually strong refractive power and a relatively normal axial length. So here is just a diagram showing an eye with myopia without any spectacle correction. So light from a distant object is focused in front of the retina. So physiological myopia is just to differentiate it from pathological myopia. And this is a low-grade myopia of less than -6 diopters, and it is usually slowly progressive until adulthood is reached, and then it becomes static. So progression may accelerate to a degree during adolescence, and the corrected visual acuity, meaning that visual acuity with spectacles usually remains normal. In contrast, pathological myopia has a high grade of myopia, which means there's a refractive error of greater than -6 diopters. It is rapidly progressive during adolescence, more so than physiological myopia, and then there's a subsequent slow progression that continues during adulthood up to about 30 years of age. Then it's also associated with myopic retinal degeneration, which may lead to permanent visual loss, and it is also associated with an increased incidence of rheumatogenic retinal detachment. Here is just a picture of pathological myopia. This is a patient's left eye, and we are now looking at the optic disc. Here is the optic nerve that goes to the brain. This area there is called peripapillary atrophy, which just means that the retina becomes atrophied around the optic disc. And then there's another area here of atrophy of the retina, and it is basically just as a result of the patient having a much longer eye than is normal, and the retina is basically stretched very thinly over the back part of the eye, over the choroid, and as a result it degenerates into this condition where there's atrophy in different areas of the retina. Then the symptoms of myopia. Myopes have poor distance vision and good near vision. Patients with very high myopia also has poor near vision, but a patient with myopia of say -2 to -3 can read very comfortably without any glasses, but their distance vision is impaired. The treatment of myopia has to be with concave or minus lens spectacles. In contrast to hypermetropia, which is farsightedness, in myopia, accommodation cannot compensate for the refractive error. So all patients with myopia will require spectacle correction or correction of the refraction with a contact lens. There are patients that opt for refractive surgery if they do not want to wear spectacles. Spectacles are always the safest option, but if patients elect to have refractive surgery, the results with myopia is actually better than in patients with hypermetropia or farsightedness. So here's just a diagram showing a concave lens or a minus lens which corrects myopia, bends the rays a little bit outwards so that when it hits the cornea, cornea and the lens, it will eventually end up focusing on the retina. So hypermetropia is the other one of the other ametropias. Here the refractive power of the anterior segment is insufficient for the axial length of the eye, and as a result parallel rays from a distant object will be focused behind the retina. Hypermetropia results from an unusually short axial length in an eye with a relatively normal refractive power. But like myopia, less commonly the eye may actually have a normal axial length, but just a weak refractive power because of the corneal shape or the lens shape. Here is a diagram showing what happens with hypermetropia. Light from a distant object, the parallel rays from a distant object will be focused behind the retina. So in hypermetropia, the symptoms are as follows. Hypermetropes tend to have better distance vision than near vision. But accommodation increases the refractive power of the eye, so that to an extent, hypermetropes can, as long as they've got good accommodation, they can often compensate for their hypermetropia and still see distant objects focused on the retina. Shown here. So when the eye is not accommodated, the light would have fallen behind the retina, but when the eye is accommodated, then distant objects will be in focus. So, but excessive use of accommodation can cause problems. It can cause eye strain, which manifests as headaches or eye discomfort, which increases with visual tasks such as reading or writing. And then convergent strabismus can also manifest as a result of the fact that accommodation is part of the near reflex, which also includes convergence. So when when somebody wants to look at a near object, they can, in hypermetropia, overshoot so that there's too much convergence, and that becomes a problem. So the treatment of hypermetropia: corrective convex spectacle or contact lens, or we can also call it a plus lens, is necessary only in the presence of one of the following: when there is subnormal visual acuity, so accommodation is unable to compensate for the hypermetropia. If there are symptoms of eye strain due to the excessive use of accommodation in order to compensate for the hypermetropia, or when there is strabismus, so that the compensatory accommodation induces excessive convergence. Here one can just see how with a convex lens or a plus lens, hypermetropia is corrected. So just to remember, hypermetropia can partially or completely be compensated for by accommodation, and as a result it can produce symptoms of eye strain or strabismus, as well as a decrease in vision. Myopia cannot be compensated for by accommodation, and so it doesn't produce symptoms of eye strain or strabismus, but it usually only manifests as a decrease in vision. So astigmatism may be a bit of a more difficult concept. So the ideal cornea has the same curvature and the same refractive power in all directions. So if one thinks about it, one can look at it as say a side slice of a soccer ball, or any round ball, where the curvature vertically and horizontally and in all directions are equal. And when a patient has astigmatism, the corneal curvature is not the same in all directions. It's more shaped like a rugby ball. Although this is a little bit over exaggerated, but it's just to show the concept. So over here, the corneal curvature in the vertical is significantly more than the corneal curvature in the horizontal, and will result in astigmatism. So when light then enters the eye in a horizontal plane, it will focus at one point in front or behind the eye, and then when light from in the vertical plane falls, gets refracted by the anterior segment, it will focus on a different spot in the eye. These are usually 90 degrees from each other in in most cases. There are exceptions which are called irregular astigmatism, but mostly it's about 90 degrees um, in relation to each other. So just to demonstrate what happens here, horizontal light rays falls into the eye and focuses at one spot, and then the vertical rays of light, parallel rays of light that goes through the more curved part of the cornea, focuses in front of the retina. So the symptoms are that people with astigmatism have blurred vision in all distances. The amount of the blurring just depends on the degree of the astigmatism, and as a result, symptoms of eye strain may occur. So the treatment is necessary when the visual acuity is unacceptable, and in that case the astigmatism is then corrected by an astigmatic spectacle or contact lens, which has different curvatures along different axes. There are selected patients that are suitable for refractive surgery, and again the same applies. It's always safer to have the eye corrected with glasses, but some people opt for surgery, and in astigmatism there's a certain type of refractive procedure called T-cuts that can flatten the cornea in some of the axes of the cornea. Then to determine the extent of refractive error, first of all, visual acuity. So distance and near vision can give an indication of the type of refractive error. So if the vision is better near than at distance, the patient is probably myopic. If the vision is at distance better than near, patient can be presbyopic or hypermetropic. And if vision is equally poor at distance and at near, the patient probably has astigmatism. Then in any patient with reduced visual acuity, repeating the visual acuity measurement with a pinhole will give an indication of whether the visual loss is organic, which means that there's some disease present, or whether it's only refraction that is the problem. So if the visual acuity improves with the pinhole, the loss of the vision is at least partially due to refractive error. If the visual acuity does not improve with the pinhole, the loss of vision is probably due to an organic defect, which just means disease of the eye. The pinhole may not improve the vision perfectly, as an optimal spectacle correction will in most cases be better than a pinhole. Consequently, the visual acuity with a pinhole may not be 6.6, even when the visual acuity with spectacles are 6.6. Then just briefly go through a few types of refractive surgery. So a refractive lens exchange basically just means a cataract operation is done in an eye that doesn't have a cataract. So the lens of the eye is surgically removed, just like with a cataract operation, and replaced with a synthetic lens of a more appropriate power that will focus light rays from distance onto the retina. Then radial keratotomy is more of historical importance. It used to be very popular in the 80s, but subsequently There were many problems found with this procedure, and it has there are very few people, if any, that still would do radial keratotomy. It's mostly been replaced by LASIK. It was an operation that was done for patients with myopia. Then T-cuts are also very deep cuts in the cornea, just like radial keratotomy, but they are made in a specific area of the cornea to flatten the cornea in patients with astigmatism. Some surgeons would do these T-cuts after cataract surgery in order to correct astigmatism. LASIK is laser-assisted in situ keratomyosis. I'll show a picture of the procedure soon. The laser reshapes the cornea beneath the corneal flap. The flap is made by using a laser or a mechanical incision, and consists of epithelium and a thin layer of stroma. Compared to previous operation where the epithelium and the stroma used to be ablated, in comparison to that, the recovery takes much less with LASIK and is relatively painless, and it's one of the most popular refractive surgeries currently. So here one can just see that with the femtosecond laser, a corneal flap is formed. Corneal flap is flapped over or flipped over onto the side. The laser then reshapes the cornea. It flattens the anterior part of the cornea in a patient with myopia, and afterwards the flap is folded back. None of these procedures are without their risks. So one must just understand the following principle with refractive surgery. Surgery to correct myopia flattens the central cornea, and this reduces the refractive power so that light from a distant object which used to be focused in front of the retina before surgery is then focused on the retina after surgery. Then surgery to correct hypermetropia steepens the central cornea. In order to do this, a circular gutter is created in the mid-periphery of the cornea. This then creates an unnatural surface shape and has a lower success rate. So LASIK is more suitable for patients with myopia, but glasses still remain the safest option. And this is the end of this lecture.